Is Jim on the line? Is he going to do any sort of intro?
I think he was just letting us take it.
Okay.
Jim, you there?
Or is anybody from West Virginia Hospital Association on? Okay.
Hi, this is Hallie Morgan. I'm on from WVHA.
Okay.
Okay, great.
Great.
Oh, I think we probably met you when we were out there.
Yes, you did. Yep.
Great.
All right. Well, thanks everyone for joining us today. We have, my name is Craig Christensen. I'm one of the co-founders of H4 Technology. We had met Jim Kranz and Hallie and the team out there at West Virginia Hospital Association earlier this year, pre-COVID. I think that right before all that hit, and wanted to share with you some of the things we're doing on proactive denial management. We have now partnered with West Virginia Hospital Association on this, and just wanted to share and inform everyone on the platform and the program we're doing. So as I'm sharing out, okay, we got Tony Tiefenthaler on the line, or on the webinar as well as Thea. I'm still admitting people, so hold on. So Tony, you want to give a background on yourself?
Sure. Hello, everybody. Glad you could join us. I'm a strategic account executive with H4 Technologies. Prior to that, I was a pop health consultant for Optum, a United Health group. And then prior to that, I was an executive at a couple health systems in the upper Midwest. So that's me.
So we're going to talk a little bit about revenue cycle management and how we can help with the denial management side and other claims tools we have. I found this on Relay Health. I thought this was pretty funny. The claims processing training course and all the hoops and everything you got to jump through to get paid. When we're talking about the revenue cycle process, these are things you guys are going through daily. The patient registration, insurance verification, provider sees the patient, there's medical coding and charge entry, claims transmission, remittance received with payment, billing department reconciles and posts, and then you have the whole denial, insurance and self-pay follow-up. So that's kind of what we focus on. Once that process is done, we have the resubmission of denied claims, and then the month-ending journal entries are posted. When we're looking at revenue cycles, so patient data and claims, things we can look at is correct insurance data equals correct claims. So are you monitoring the delay between the visit and the billing? How long does this take? What are the primary reasons there is a delay? When we're looking at the payment schedule, is someone monitoring the claims payment process? And then denials. What are the top denials you guys are seeing? We know from our client base what is around, but it kind of varies by payer and by geographic area. And then is there a denial management process for corrections and appeals? And then how long does this take in your facility? When we're also looking at the denials, we're looking at tracing those denials back to the source and maybe the process. So is there a front desk patient eligibility question? Is there incorrect primary insurance information? Those are common things we're seeing. From the provider perspective, there could be incorrect coding, expired codes, documentation not complete or signed, services not covered, provider not eligible or credentialed. And then the billing staff could be missing information on the claim, such as modifiers, or there's a duplicate bill instead of an adjustment of the claim. On the claim submission, there's timely filing limits, obviously 180 days in most payers. And we've worked with a variety of clearinghouses now, and there's clearinghouse reports, some are better than others, to help monitor this and help resubmit the rejected claims. Then we also recommend the review of credit balances. Is a refund due to the patient or the payer? Is the contractual reduction correct? Generically, open communication, documentation, set definitive standards, timeline, and educate staff on the denial and avoidance. When we're looking at, I think when we look at claims data management, the average denial rate in the U.S. was around 10%. There's a higher percentage of more Medicaid-funded populations. Our average denied claim was around $1,100, and denied claims take 16 days longer to pay. So all this is impacting your cash flow and the processes of you guys getting the money paid to you. One area we want to focus on is that 63% of the denied claims are recoverable. And so that is the portion of the denied claims that you guys can directly impact your organization. So what
Greg, can I stop there just a minute? We've done some work in West Virginia, and I just want to say you've got some, a large amount of your population is covered, but you've got some challenges there with all the different programs that are available with the Medicaid expansion, the state employee health plan, different things like that. And we are seeing 10% in denials, where maybe here in the Midwest, in Nebraska, South Dakota, we're seeing maybe 3 to 4%. So just want to share that bit of information with you.
Yeah, so we're doing a claims data management platform for a variety of providers and statewide associations and others. The key component is that we're directly integrating the claims from the claims clearinghouse. And so we set up a direct connection so we can get daily files from the clearinghouse for you. We have 837 claims submitted, 835s are the other claims data set. And then we have analytics on payer, provider, CPT code, timeframes, those type of things. We also built in reference tables for the CARC and RARC codes on the denials. And so, 16s, you don't have to memorize the table or know what they do with, what those mean. And we'll show you what we're doing on that. Additionally, we have now claim reconciliation process. So if we get both data sets, the 837 and the 835, compare those, and then we can look at fully denied claims, partial denied claims, and complete adjudication. And so those are the benefit of having both of those data sets and working together. The analytics we have, by payer graph or by CARC, generally we see people, filtering by payers, comparing payers and CARC codes across each other. And they use this to identify gaps in process, optimize the process upstream, and then continuously monitor that. So when we're looking at common delays, what we're seeing across our group or our clients, generally there's a lack of information or the proper information documented. So that's a 16 code. So you can see the claim lacks information on the claim. Others are like plan procedures are not followed, services not documented in patient medical record, that's at 7%. Coordination of benefits is another big one, and there's several RARC codes around that. So that's a 22 code. This care may be covered by another payer, and we see roughly 5%. And then we have a whole gamut of others that are around 1 and 2%. Timely filing limit has expired. Patients can't be identified as insured. Prior authorizations. And then another recent one that's come up on a couple different groups are charges are covered under capitation agreement. So really depends on the organization and the payer mix that they are using. But these are the types of things we can do and show.
And I think that Yeah, and I think that 24 is we're seeing that being more and more important with our clients, because if they're not getting paid for a claim submitted, they want to make sure that they're getting a capitation amount. So that's for kind of a trigger for them to go back to see if they actually did get capitated amount. So
Yeah. So once you have the CARC denial codes, then you can look at the RARC, which is the remittance. And so this provides more detailed documentation on the denial. And so, you know, it's not covered service procedure, incomplete, invalid, itemized bill, healthcare policy coverage is primary, maybe it's a duplicate. Others that we're seeing consult, you know, plan benefit documents for restrictions on the service, missing payer identifiers, policy not in effect for this date, and not covered, you know, when considered preventative. And so that's all based on the policies, and a lot of those are the individual patients' coverage and the date of service, or you know, justification of the services. So this can help you identify those, dive into the exact patients where those are happening and payers, and then even across larger groups, we're seeing them compare providers. And so if we have a percentage, an average percentage for denials rate per provider across the group, then they can look at best practices across those providers. One thing on the 835 and 837s, we did claim line reconciliation now, so we can match the 837 back to the 835, or 835 back to the 837 to determine if all claims filed with the payer have been processed. This is an ongoing process we developed. There's full, partial, and incomplete adjudications tab, which show the outstanding claim lines with dollar amounts still need to be processed by the payer, and a whole bunch of filters for, you know, interactive dashboard by payer, provider, date range with the claim line detail. All this data can be exported if you wanted to create a list for your billing staff to go through and identify. And so other things we're working on, and we will roll out next month, is this age trial balance dashboards. And so these are filters by payer, provider, and time frame. And what we're comparing now is the date of service to the build. And so we'll have bucket ranges, 0 to 7 days, 8 to 14. You can see them there. And then we can multi-select and filter by provider, the time frame, bucket, or payer to compare. So how are the payers' data service to actually the build? And so you can look at your internal processes by payer. The other pieces we're looking at are build amount to payment. So once again, that'll be 0 to 30, 30 to 45, and on up. And so this is, you know, when we created these, we partnered with a RevCycle and CPA audit group that were struggling with this for their clients. And so this came out of that discussion, and will help them quickly identify areas to improve. Other ones we're doing the data service to the actual payment. And then as we roll and aggregate this data, we'll have benchmarks, a 12-month trend, and then we can compare, you know, obviously if you're on that service for year over year, you can compare last year to this year, or month to month. So
I think one of the really nice things about that, Craig, this is Taya, is that once you have the age trial balance dashboard and you're reviewing it, you have the opportunity to see what is really slowed down as far as remittance velocity. And then you can go back to those claims adjustment and reason adjustment screens, like Craig mentioned, and filter in to see what's creating that slowness. So it's another way to kind of red flag for your rev cycle team.
And folks on the call, feel free to ask questions or put a question in chat if you have any comments or questions, and we'll monitor the chat.
Great. So on the actual denials analytics itself, we got one more person admitting here. Okay. So we created, we started with the 835 denials. And so we're looking at denials overview with interactive tabs. So this is, you see, and we'll show you a live demo, but the current quarter is by week. And then you can monitor your denials by week. And so this allows you then to filter by payer, procedure code, the CARC or RARC codes, date ranges, providers, and then even in multi-tenant groups, you could filter it by the client ID. So if you had multiple locations or multiple hospitals. Then we integrated the Washington Publishing Company and set up these use case tabs. So these are specific CARC and RARC code combinations for use cases. So there's a missing, invalid, and complete, missing, invalid, and complete data from submitted, billed service not covered by the health plan, benefit for billed service not separately payable, outliers, and then an approved claims tab. And so the outliers we created because not all payers were following the correct CARC and RARC code combinations. And what generally we were finding is Medicaid and social services generally fall on there is what we're seeing. Maybe not the big payers or the Blue Cross, Blue Shields of the world. So that allows you to go back to those denials and look specifically for those CARC and RARC code combinations. And so we made it easier and grouped them for you so you can just go to those tabs. You still have all your filters and you still have the ability to look at the claim detail, payer, procedure codes, CARC, RARC, and then even patient information. Any questions on that? Tabs and the
What's good about this, I think, is as you start using the tool, if there's specific CARCs that you've identified that you need to change the process, since we're blowing in the claims every day or every night, you can then start to look at if you had a registration issue or a timely filing limit or something, you can then see how you're trending. If the corrective action that you've taken, are you seeing the outcomes or the results of those corrected actions? So.
Okay, and so what we are doing now is we, upon working with a variety of providers, we'd load the data and then it was kind of we train them on the platform and then we would ask, there'd be, well, what do I do first, right? And so what we ended up developing is this claims improvement template. And so we'll roll through the initial data that is sent to us and group and classify the highest denials in your data. And so by payer, by CARC code, and then we have a rev cycle resource that will work with you on the initial assessment, I guess, free of charge to look at these and then provide their insight. And so this is the top denial codes, the highest denial by payer, and then there'll be commentary on what that means and what are the corrective actions or things that you should look at going forward to help reduce that percentage. And so if you're, don't know what these are or aren't monitoring these, on a regular basis, I would highly recommend that. The second piece of that is, the missing information, and then, I think the RARCs is where we go. So we look at top denial rates by payer, and then look at the RARCs, and then see what we can do and what recommendations we can make for you. So this is a free template that we put together for all new clients, and bring it on board to help them use the platform, understand the data, and then obviously have some impact and ROI to what they're doing.
And typically what we try to do when we bring someone up, it's really up to the clearinghouse or the client. But let's say if we bring you up in September, what we'd like to do is get your year-to-date 835 claims data, so that we have some history since the first of the year, so you can have a good idea of what's happening with your paid claims and where there's opportunity to improve. And then we then start to take daily files from your clearinghouse or from your IT department. And then on the 837s, what we want to do is start to go from that day forward. You go live with us. That's when the 837s come in. That's typically easier for clearinghouses to send us ongoing 837s going forward rather than historical. So just an FYI on that. But that makes this template very, very rich if we've got some history in the platform.
All the data we capture, we put into data models, and then have our standard dashboards that everyone has. And then we also enable this self-service tool. And so this is where you get down to the 835 and 837 claim detail, and you can sort and filter and build your own reports and export data. And if you really have issues you want to research and resolve, this is where we train people and have people go to look at specific issues. Basically, the premise is you have a data set, a data model, you select the fields you want to include, and then you can filter on those fields and have your own bar charts, pie charts, line charts, tables, all that available to create and save per user. And so that is the data basically at your fingertips to help answer questions as you guys are working through the tool. So I'll jump into a demo here real quick.
The other thing is, as Craig's getting ready for the demo, is, if you've got specific issues with your payers and you have a contracting person in-house that you work with, you can actually download the specific issue that you're having with the particular payer. You have the claim line detail there, and then you can send it over to your contracting contracting person to work with a specific payer. Or if it's a large enough issue, and Haley, I'm not trying to give you any work, but if there's more of a trend overall with a particular payer in your state, maybe that's something that you could reach out to your hospital association for help. So just want to mention that. Haley, I hope hope you're okay with mentioning your name.
Absolutely. We are here to help and support. Yes.
Go ahead. Yeah, because that's what we're seeing with other associations, is that they can provide, and I think that's one of the reasons why West Virginia wants to help promote this, is they can be a resource for you and add an added value with some of those maybe more difficult payers that you're maybe dealing with in your state. So
this is the analytics and dashboards for the 835s. So as we can see, we have different tabs and different charts for each tab. The filters are that plus button, so I can hide and expand that, and then I can search on certain cart codes and or specific payers. And so at the top here, we look for the week and quarter, And then we can see, okay, we got $89,000 in that current bucket, and 663 claim lines. Down here is my payer mix, so I can easily hover over the different groups, see the percentages, and then look at the total line item charge amounts in that denied bucket. On the other chart here is the top 20 procedure codes. So this helps us identify if, which procedures are being denied. And then, is it one, large claim or claim line item for a big dollar amount, or are you getting, kind of denied, this one's, $5,600, but we got 59 total procedures that are denied in there. So are you getting, cut a million times here, whittled down. So all this, we have the procedure codes referenced, we have the CARC and RARC codes referenced, and then the payers come through the claim information. As you can look and hover over, we have the same CARC and RARC codes that I showed in the previous slide. So here is, what we have, 26%, 23 grand of that was the 18s, and then you see that full CARC description, so you don't have to remember what that means, exact duplicate claim service, right? I can hover over we recommend just starting with the biggest chunk of pie. This 97's benefit for this billed service is including the payment allowance for another service, right? So we can easily filter or look at those specific ones. On the right here is the RARCs. So if I wanted to look at specific, not covered when performed during the same session or date, I got missing, invalid, incomplete information on the National Drug Code. And so there's a variety of those. So generically, we have people filter on the payer. We'll go up here and look at payer. Just our example. Apply that filter. Apply that filter. So I got 26,000. Here's my denials for that Blue Cross policy. And so I can see, okay, what's happening with those codes. What is my CARC description? Plan procedures are not followed. Claim service lacks information. I can further refine on those. So if I wanted to look at those 16s, I can go back up here and add my 16 code. Just type in 16, or you can start typing. And then we pull up, okay, I got for that current quarter, $7,000 for, and then here's the actual CLARCs and claims and patient detail for those claims that have been denied. All this data in the data table is exportable, so we can export that if you wanted to create this as a list or just a working list for you guys. And then you can work through the data as you see fit, and what as it's continuously updated daily, then we have that ability to recapture and recognize that revenue and resubmit it. So
the other thing is, from an advocacy standpoint, from the Hospital Association, I don't know what's on your plate as far as the next legislative session, but I attended the Arizona MGMA legislative update, and a couple of things that they've tackled in Arizona this past session was the prior auths and how they wanted to streamline that process, and they were working with the state legislature on that, and then also justify increases to the state Medicaid fee schedule. And then when I was talking to the association, I was talking to them about how if their members had a platform like ours, they would have that level of detail that could be helpful as you're trying to lobby and advocate for changes. Haley, if you want to learn more about that, just let me know, but I can share with you some more detail.
Okay, great. Thank you.
So as you can see, we had those different tabs. So we just went to the build service not covered by health plan. So I wanted to look at these. So which procedures, were these? We had, UB92 codes. We had office visits, therapeutic groups, and then okay, what are the actual part codes for that? So we have these timely filing limits would be one I'd want to look at. To make sure that doesn't happen in the future. And so these are ones that you can easily massage the graphs, filter on what you need and what's the biggest chunk of your pie, and then take that claim detail as an action step to work towards. So any questions on the filtering or the data charts or anything that we have?
The other thing we get comments back from our clients is, once they go live with us, they see where there's opportunity to improve. But once they do make the improvements, they still want to use the platform because there may be some things that a payer does arbitrarily that they won't even recognize in some of their and how they process their claims. So having the ability to go in here and maybe you suspect something's happening with a particular payer, or they're bundling some codes, or they're not processing a correct modifier, you can go right in here. You can look at what's happening overall with what your concern is, and then you can also look to see, okay, I'm getting paid from 80% of my payers on these particular claims, but 20% are not getting paid, and why is that? And we need to take the necessary steps to address that. So, kind of an ongoing monitoring platform as well.
And so we, the nice thing is we're a SaaS service, and so we're doing this for, I guess we're partnering with 4 state hospital associations right now. As well as individual providers, and we got a ACO group using this, and so the charges are real reasonable. So we're charging $250 per user on the platform, and then there are enterprise deals if you had multiple users, and then just a minimal setup fee just to do that direct connection with the clearinghouse and get that data on an ongoing basis. The good thing is that as we've grown and expanded to these other states, we got roughly 20 connections already established with clearinghouses and EMRs and different groups, practice management systems. And so, generically, we can leverage that infrastructure for your members. And so I think right now, the platform, what we're doing is the platform is a SaaS-based platform. So we add, take for example, the reconciliation process that went live in June. Well, that was something we did as a specific initiative for one of these groups. Well, we actually enabled that for everyone. And so we can, the benefit of the group and the development that we're doing on the 835s and 837s benefits everyone that's on the platform. And so the reconciliation is a direct result of that initiative, as well as the age trial balance. And so we like to be a partner with the people we are working with, and feel that there's a lot of value in the platform itself to identify exactly what's being denied, and then working on the processes to I guess reconcile or review that, improve that. So, any questions?
Allie, do you have any comments based on what you what you saw in the webinar and what you've seen in the past when we were out there?
No, I think it's great. You know, liked what I saw again, and we appreciate you speaking to our members about what you guys have to offer. So
great.
Yeah, I'll send out the PowerPoint to everyone that registered, and then we recorded the webinar, so we can send that out as well. And then as just the claims review template that we built, I can send that as a blank template. I think it's a worthwhile process if you don't know your top denials and percentages by payer. Take a look at that. That's something we do once we get the data in and can analyze that for you. But it's a good exercise to go through regardless. And so I'll include that in the email as well. And so as you guys are looking to improve your operation, just, you know, the best copying what other people are doing is probably an easy step to do it. So I'll include that as well. If there's anyone interested in a more further demonstration or discussion, please reach out to us or to West Virginia Hospital Association, and I'm sure we'll be in touch with Jim and Hallie and the team as well. Okay.
Great. Thanks for your time.
With that, yeah. I think we'll conclude, and I appreciate everyone taking the time out of their day. Thank you, guys.
Thank you. Have a good day.
Thanks.
thank you.
Thank you.